Have you seen the ads advertising testosterone? They're everywhere. So I got to tell you, I've been, I do my share of viewing social media.
Yes, you do.
And scroll through this stuff, probably for no more than a minute or two a day.
Oh, not even that.
But all of a sudden, testosterone ads are everywhere. You can't avoid them. Tony Robbins, I don't know if it's him or if it's some AI representation of him.
It's true.
But, like famous inspirational speaker, author is out there hawking testosterone products. Talking about how it's going to improve performance and sexual performance and workout performance. There are ads for home testing kits and all this. Now, maybe I get a lot of it because
that's true.
I follow stuff and I put out stuff around testosterone. So I don't know if I'm selected for this. But I've been looking up testosterone stuff forever. And all of a sudden, this is what has happened. And also within the last just several weeks, I've had 3 major media outlets come interview me around testosterone. And it seems like so there's a lot of interest these days.
Right. What is with this explosion? Do you know?
So I asked all of them, what...
Before we start, a small disclaimer. The Sex Doctors podcast is not a substitute for medical or psychological advice.
Welcome to the Sex Doctors, featuring Dr. Marianne Brandon, clinical psychologist and diplomate in sex therapy, and Dr. Abraham Morgentaler, renowned urologist and expert in sexual medicine and testosterone therapy. Together, they bring you expert insights into sex, intimacy, and relationships. Let's dive in.
I believe in miracles. Where you from?
Prompted this. I thought maybe there's a big study coming out that I wasn't aware of, although I'm usually know about these things. And the story was that RFK Jr., who's going to be put up as head of Health and Human Services by the new administration, that he had mentioned in a podcast that he was taking testosterone. So all of a sudden, there's a lot of interest in him. But I don't know if that's all related to these ads or not. And I just have to tell you that I have what I regard for myself as an odd reaction to this. And one is that I've been advocating for decades that we need to have greater awareness.
Yes, you have.
Of the prevalence and the importance of being deficient in testosterone, what I call testosterone deficiency. Other people traditionally have called hypogonadism. And that it's under-recognized and undertreated. So on some level, I would argue with myself, well, what are you worried about? Like, maybe this is good. But I don't like it. My reaction is 100% negative. And I've been trying to figure that out, and I just thought I would talk to you about it with, in a private conversation with whoever else is listening in. Because it's weird. And part of, I think, what the reaction is that these ads cheapen it.
Yeah.
They make it seem, and this has always been true, they make testosterone therapy, which should really only be used in people who are deficient, they make it seem too good to be true. Now,
like a magic cure.
Magic cure for whatever it is that ails you.
Yeah, not about being deficient, but how it can sort of like make things better.
Yeah. And the audience that I've been wanting to sort of really get the idea that we're not looking for this enough, we're not treating it enough, are really what I would call the mainstream doctors.
Yes.
Sort of what I might be called institutional doctors or hospital-based medical community. Because a lot of the testosterone outside of urologists who tend to be pretty savvy and open about this, because we're often the experts in sexual medicine. Apart from those, a lot of the docs who do prescribe testosterone have tended to be seen as alternative type doctors.
Right.
Doesn't make what they do wrong, but they've been regarded suspiciously by sort of the hospital-based community. And, and I'm an academic, right? Like, the Harvard through and through, papers, science, and most of my colleagues are in the same areas, right? And so there's been resistance within the general medical community to doing this. And some of the arguments that we've been trying to overcome have been this idea, and there are papers that suggest this, that testosterone is overprescribed and abused already.
Mm-hmm.
And so I think this fits into that narrative.
It does. But have you seen, at least up until this point, testosterone being overprescribed? Like, I'm
So
not,
I have to tell you, embarrassingly, I'm an author on a paper that has been used to suggest this is true. But it's interesting what data are and how they get interpreted.
yeah.
So there's an excellent researcher. His name is Jacques Baillargeon. He's at the University of Texas in Galveston. And they do a lot of public health work and epidemiology. And so they've accessed these large databases. And what they looked at was you can look up everything that's coded. So prescriptions get a code,
Mm-hmm.
diagnoses get a code. And so they looked at individuals who got testosterone prescriptions and whether or not they had a testosterone test obtained before the prescription.
Oh, okay. And so you found
And in
that they weren't getting tested.
approximately 25% of the cases,
Uh-huh.
they didn't have a testosterone test in the record. Now, these are electronic health records, okay? And that's a big number.
Yeah.
The weird thing of the story, though, or sort of the finding that gives some insight into where things could have gone wrong in the interpretation is they looked also by who had seen a specialist, like a urologist, and or an endocrinologist.
Oh, so they could have had their level done at the GP or something before they even arrived there.
So you're getting there. So listen, so the findings were that for the endocrinologists
Mm-hmm.
who were seen before the prescription, 20% of them didn't have a testosterone test. Now, this is not believable.
Mm-hmm.
It's not believable because endocrinologists tend to be very careful,
Yeah.
and everything they do is based on blood levels.
Right.
That's the entire field.
Right. So how did that?
And you might have one rogue endocrinologist or two out there, but not 20%. So it's not believable. So there's something wrong with the data.
Yeah.
Now, these data are a little bit older, but still it might happen even if we did it today. And basically not everything gets captured in these electronic health records. And as we were going through this, so I was invited to be an author, to be part of this, look at the data and publish it. The data are what the data are, right? They're worth being published. The question is, what conclusions do you draw?
Yeah.
So, and so I wanted to know before we published it, could we actually look at some of the individual records of some of these patients?
Uh-huh.
Because it seemed to me that they might have a testosterone level that came from somewhere else. So this is an insurance-based data set
Mm-hmm.
where if the blood test wasn't paid for through insurance, it wouldn't show up.
I see.
So if you went to a doctor who did testing on his own or sent it to an outside lab, but said, sorry, we're a cash-only business for this, which a lot of
They are.
hormone stuff are,
Yeah.
it wouldn't be recorded.
No.
But he might come with that legitimate test
Yeah.
to his doctor,
Yes.
even to the endocrinologist who sees maybe 2, maybe 3 levels and says, okay,
Mm-hmm.
I think you got the condition, I'll prescribe for you.
Mm-hmm.
But you won't find that test result in the electronic health record.
I see.
And there were reasons that have to do with there were reasons we couldn't actually access any of those records, individual records. It's a different kind of consent, and we don't have that. So anyway, but that's one paper, in there are a few like that have been used to suggest that it's all being done wrong, right?
Yeah.
Not with enough care. And so now we have this spate of ads that just says, hey, look, get it done. Your workouts will be better. The girls will like you, right?
Yeah.
You're going to be a new man. And the weird thing is, if we're honest, of course, I've seen that actually does happen to a lot of the guys. But boy, it makes me uncomfortable. And the FDA is a problem too, So the FDA hates testosterone.
They had a lot of things, wouldn't you say?
They hate a lot of things, but they certainly hate testosterone.
Uh-huh.
Now, they've approved a whole bunch of products, but that's because it's hard to deny reasonable products when testosterone has already been around for 80 years, right? So, but they've worked hard to restrict who actually is officially indicated for testosterone, and they have the potential to make it harder and harder for doctors to use it. It's already a controlled substance.
Yeah.
That means that it's harder to get it. They've added black box warnings that scare some doctors and some patients into thinking maybe they shouldn't be using it. So that's what I worry about.
I understood. Do you want to comment on the black box warnings here?
So the black box warning is around high blood pressure associated with some of the newer testosterone products.
I see.
And I have to say that data is not strong at all. Longer term data do not show that testosterone increases blood pressure on average. And in some studies that have been followed, blood pressure falls, especially if weight falls too, which can happen with testosterone.
So what about the consumer? They see these ads. They feel like, let's say they feel like they legitimately could have low testosterone. What do they do? How do they proceed?
Yeah, I think it's really important that people do get blood tested in some reputable by reputable, that's a hard thing to define, reputable physicians, right? And it has to be gone about in the right way. Like this is a prescription medication. Whether it should be controlled or not, it's a controlled medication, which means doctors have to be careful. Each state has laws that govern this about how it needs to be locked up and dealt with and prescribed. And for people who truly are testosterone deficient, by all means, seek attention, get evaluated if you really have low levels of testosterone. There's a lot that testosterone can do to improve the quality of your life. That part is all true.
So what if they go to their doctor and their doctor says, either I'm not going to take your level or your levels are within the low normal range and we're not going to do anything, which you're going to hear a lot. Particularly, that's what you're worried about. These doctors are going to sort of like have a reaction to all this in the news, just as you are, or in the media. So what do they do then? What does this patient do then when their doctor pushes back?
Yeah, so a couple of things. So I think you have to find yourself a savvy doctor. A lot of primary care doctors just aren't doing this work. They don't like it. They don't understand it. They think maybe it's associated with risks. Most of those risks, all the big risks, there really have been put aside now, set aside by wonderful evidence. So cardiovascular risk is a 10-year-old phenomenon, didn't really exist as a concern before about 10 years ago. And now there's a large study called Traverse that showed there's no greater risk with testosterone than with placebo for heart attack, stroke, and death. Simply not true. Prostate cancer has been a concern for decades and decades, and also not true. As a matter of fact, testosterone is now being used in high doses to actually treat some men with advanced prostate cancer.
So that we do have to do a show on.
Yeah, unbelievable change.
Yeah.
So, and then there's the question of if you do get evaluated and you're told, well, your level is low normal, I don't think it's low enough to treat. Most doctors trained with total testosterone, and the better indicator of a man's status is actually free testosterone. Most docs don't know about that. And then there's an added problem. The issue really is complicated, which is that the reference ranges given by laboratories, like the values for what's low and what's high and what's good and low, aren't clinically based. They're not based on people.
So that is just as an outsider to medicine, almost impossible for me to really believe.
I know that part's a mess. It is a mess.
How is it possible?
I started this off with the rant about all the marketing.
Yeah.
But some of this is almost like self-inflicted wounds.
Yeah.
Right? From the medical doctors that have been involved with testosterone research, is that there's too much lore, L-O-R-E, like old fables that it still inform how we manage these things. This is how bad it is. So in the United States, there's two main organizations, the Urological Association and the Endocrine Society, American Urological Association and Endocrine Society. They have guidelines on testosterone. They're both people who wrote them, both have super intelligent people who have looked at the literature, and they don't agree on what a low level is.
Yeah.
So the urologists say it's less than 300. FDA uses 300. This is nanograms per deciliter. Endocrine Society has to be less than 264, which is pretty darn low. You have to be really low to qualify. This is for total T. Guess what? The Europeans who use much less testosterone than we do in the States, they have a much more generous, or you might say liberal, attitude about it. And so they use a value less than, it's approximately 350 nanograms per deciliter.
That's very civilized.
And with comments that the blood tests may not always reflect what a man's true status is, because it's just levels within the blood, but not in the tissues.
There you go.
So you can even recommend a trial of treatment for somebody with normal levels.
Wow.
You don't see that in the American recommendations.
No.
So how is it that you have smart people that can have such different thresholds? Well, part of it is just, as a matter of fact, the whole idea that you have to pick one number and you're either below it or above it is by itself bizarre, because humans vary biologically a lot, right? And their set point, or their thermostat, if you will, for testosterone is going to be different from one person to another.
Yeah.
One person at a level of 275 can be extremely symptomatic, and another person may not be bothered at all. That person probably doesn't need to be treated, but the one who's symptomatic may benefit a lot from it.
Right.
So we've actually failed. In the medical field around testosterone has failed in not being able to provide clear-cut, reasonable recommendations about how you identify men who actually might benefit, and then how to go about treating them.
So that being the case, you can understand why the FDA doesn't necessarily take a stand that you would say makes medical sense, because they're not getting that kind of feedback from physicians to kind of make those determinations. Is that fair?
Yeah, I think it's a different story with the FDA. You know, the FDA doesn't govern the practice of medicine. They don't govern physicians. They govern the pharmaceutical and cosmetic industry and the food industry too. Food and Drug Administration, right? But within medicine, we're talking about the pharmaceutical companies. For whatever reason, medical doctors defer a lot to the FDA, even though the FDA is not in the business
Isn't that fascinating?
of providing guidance to physicians. They're not.
I bet you if you quizzed many physicians, they would not even really realize that.
Yeah. I'll tell you how bizarre that relationship is. One more little mini rant. So if you give a lecture for what's called a continuing medical education course, right? It has to be accredited. The doctors attend. They have to gain credits, a certain number every year or 2 years to keep up with their license. So they have to go there. So these are physicians talking about the best ways to do whatever the medical problem is. Could be glaucoma, could be diabetes, whatever. If you're going to speak about something where the FDA has said a drug isn't necessarily indicated for a condition, it's called off-label.
Right.
Right? So, and in every field, there are medications that are used off-label without the blessing of the FDA for whatever reason. It works. In order to get on-label, companies have to do studies that are expensive.
Very expensive.
To get the FDA to approve it, which they may or may not, depending on the study, whether they like it. And some things are being used that are old. Nobody has a patent on it anymore. So nobody can make their money back. Nobody, meaning pharmaceutical. It's not worth their while to spend millions and millions of dollars on a trial where they're not going to make their money back because it's generic.
Yeah.
Right? So every field has some of these medications that we use. We certainly do in urology. But technically, we have to warn everybody, if we're giving a lecture, that it's off-label. And It's totally unclear to me, makes no sense to me why we have to do that. If there's any kind of governing body about what is legitimate and what isn't for medical practice, it's the medical societies.
You would think
Right?
so.
It's not the FDA.
Right.
And yet the medical societies somehow are bowing down
Wow.
and deferring to the FDA on this.
Wow.
I think it was probably well-intentioned at one point, and now it just makes no sense. Anyway, that's my mini rant about that.
Fair enough, but I don't know that we made you feel any better about all.
I feel so much better just getting this off my chest. And you're such a good listener. Give us a thumbs up or a positive review, and we love it when people subscribe. And thus ends another podcast of The Sex Doctors. Bye-bye.
Thank you for listening to The Sex Doctors with Dr. Marianne Brandon and Dr. Abraham Morgentaler. Be sure to subscribe, leave a review, and tune in next time for more expert advice on sexual health and relationships.